A very good evening and a warm welcome to all of viewers. I'm Dr. Shitil from the Clinical Engagement team here at DocPlexus. Welcome to a brand new series of ClinShot, your clinical dose of short and focused discussions for you, our healthcare practitioner who seldom have any extra minutes to spare. We have started with a new short series with niche discussion every month. You can watch us live every Tuesday, 6 p.m. exclusively on DocPlexus. This month, we are dedicating this series to neurology. Deep brain stimulation is becoming an increasingly common therapeutic option for patients with Parkinson's disease. The most common target for this includes subthalamic nuclei and the globus pallidus internus. Since its approval by the FDA in 2002, deep brain stimulation has experienced significant technological advancements. Therefore, a good understanding of these innovations can help significantly improve patient care. To tell us more about deep brain stimulation in Parkinson's disease, we have with us Dr. R. Ramnarayan. Dr. R. Ramnarayan is a renowned neurosurgeon with 25 years of experience in the field. He completed his MBBS from Medical College Trivandrum in 1988 and his MCH from NIMHANS, Bangalore in 1999. He has numerous national and international papers to his name. He is the member of several prestigious organizations, including the American Association of Neurological Surgeons and the Indian Society of Stereotactic and Functional Neurosurgeons. We welcome you, Dr. Ramnarayan. It's a pleasure to host you here today. I would request you to kindly commence the session.
Good morning, friends and colleagues. Today, I'll be talking on a very common problem called Parkinson's disease and how surgery has come forward in a big way to help those patients with Parkinson's disease who are not benefited from medical management. Before I go forward, I will just tell you what is restorative neurosurgery. Restorative neurosurgery has basically 5 types of surgeries. One is deep brain stimulation, where we put electrodes into the deep parts of the brain for various conditions like movement disorders, psychiatric problems, addiction, chronic pain, etc. We do intrathecal pumps like morphine pumps and for various types of pains, including cancer pains, and intrathecal baclofen pumps for all types of spasticity and vegetative state, all these conditions. The third is spinal cord stimulation, which is done for conditions like failed back syndrome, diabetic neuropathy pain, cardiac failure, so many other painful conditions. Sacral nerve stimulation is another surgery which is done for sphincter disturbances, that is people who have bowel and bladder disturbances. And finally, vagal nerve stimulation is also part of epilepsy surgery as well as for depression. So we'll just go to the topic proper. What are movement disorders? Movement disorders are conditions which affect the speed, fluency, quality, and ease of movement. So there is abnormal fluency or speed of movement, which is called dyskinesia in medical terms, which may involve excessive or involuntary movements, which can be hyper or reduced movements called hypokinesia. The common examples of movement disorders include Parkinson's disease, various types of dystonias, essential tremor, etc. The commonest movement disorder that's being seen nowadays is Parkinson's disease. Actually, Parkinson's disease is named after a person called James Parkinson, who first described this disease in the 18th century. This disease manifests with tremors, rigidity, slow movement, poor balance, difficulty in walking, etc. It affects about 1 to 2% of people above 60 years, but in India, it is seen in younger patients also. That's up to 15% is supposed to be seen in the younger patients. This is a map of the world Parkinson's disease scale. The more the red, the more the problem. So you can see here in some areas, the Middle East is more common. In Canada and the US, it's very common. In European countries, it's very common. In Australia, it is more common. So actually, they call it a disease of the white man. But nowadays, there's nothing like that. It is commonly seen in many conditions. And in India also, the incidence seems to be increasing tremendously. What are the usual signs and symptoms? Parkinson's disease signs and symptoms may not be common to everyone. Early signs may be mild and go unnoticed. Usually, it is unilateral and which becomes bilateral over a period of time. So ultimately, both sides get affected. The common symptoms include tremor, which is called a pill rolling tremor. That is, it's like this. The tremor is like this. Like somebody, like this prayers, people do prayers and all that, not a rhythmic shaking, which is usually at rest. And this is a resting tremor and does not happen during activity. The other thing which people notice is what's called bradykinesia, or very slow movements, where patients become very slow. Even the routine things they do become very slow and time consuming. The third problem is they notice is rigidity, that is stiffness of the muscles, which cause difficulty in moving, as also severe pain. The disease also can cause impaired posture and balance, but this usually is towards the later stage of the disease, not in the initial stages. Loss of automatic movements, a decreased ability to perform unconscious movements like blinking, smiling, swinging. In fact, that's one of the things which we learn in our younger days, is that younger studies, is that Parkinson's disease is called masked facies. That is, there's no expression on the patient's face because of loss of automatic movements. Speech may become soft, slurring, or patients hesitate before talking, and it's more like a monotone. Writing changes is seen in a lot of people, especially people like accountants, bank officials, things like that. A lot of them diagnosed or they become aware of the problem because when they sign the checks and things like that, the handwriting becomes different, and there are many people who come to us and complain that the banks are now rejecting their checks. This kind of problem is called micrographia. What are the risk factors for Parkinson's disease? Age is obviously, as I said earlier, age is definitely a risk factor. Disease usually should be seen in 60 or above, but unfortunately in India, it is seen more in younger adults also. There's actually a separate subdivision called young onset Parkinson's disease. And we have seen patients who are even 35, 40 and all that. Heredity does have a role, even though it's not very, very strictly earmarked. There is definitely a role for heredity. And obviously, men are more likely to develop Parkinson's disease. There's been a lot of study on the exposure to toxins, and there is enough evidence to show that pesticides is more common cause of Parkinson's disease. In fact, that is why if you take in my practice in Chennai, or in our practice in Chennai, if you see, you get a lot of patients coming from the agriculture areas of Tamil Nadu, like in Tanjavur, Madurai, that areas, as well as from the agriculture areas of Andhra Pradesh, like in Nellore, Guntur, Kadapa. These are all agricultural areas. So you get a lot of patients from these patients. What are the complications? Thinking difficulties, depression, swallowing problems, chewing, eating problems, sleep problems, bladder and bowel problems, dysfunction with smell, blood pressure changes, fatigue, pain, and sexual dysfunction. These are some of the complications that happen in the long term because of this disease. So practically, you can see that the quality of life of the patient is significantly affected. So how do you treat Parkinson's disease? So before that, I will just briefly mention why people get Parkinson's disease. There's a substance called dopamine, which is in the brain and which is responsible for normal movements. This dopamine gets reduced in the brain, and that is one of the reasons for Parkinson's disease. So obviously, when there's a deficiency of a particular chemical or particular substance in the brain, in the body, we just have to replace it. So treatment of movement disorders is usually by drugs predominantly and are very effective in most cases. And the usual drug that is given is a levodopa and other what you call dopaminergic drugs. That is drugs which improve the quality and quantity of dopamine. Levodopa is actually dopamine in a absorbable form. There are other drugs like anticholinergics, amantadine, dopamine agonists, selegiline, COMT inhibitors. All these drugs are all given to combat the disease. And usually they are very effective, especially for the initial stages. But unfortunately, a good number of patients come out of the good control in the long term or develop side effects of the drugs. That is, they develop hallucinations, dyskinesia, drug-induced dyskinesias. The efficacy becomes very less. Initially the drug may be acting for 6 to 8 hours, one dose. But over a period of time, this becomes for 3 hours, for 2 hours, like that. Some patients for less than 1 hour it takes. So obviously they take more and more drugs, and then naturally the side effects start happening. These patients who are not very well controlled with medicines are the surgical candidates. That is, in our medical terms, we call it failed medical management. Either the drugs are not effective or there is a significant side effects of the drugs causing a lot of distress to the patients. Previously, there used to be surgeries called thalamotomy, pallidotomy, etc., and being done. But nowadays, the surgery that's being done is called deep brain stimulation. The subthalamic nucleus deep brain stimulation. We call it STN-DBS. The subthalamic nucleus is part of the brain which has a control over the movement of movement. And we found that it has been found that stimulation of the subthalamic nucleus can cause very good improvement in the symptoms of the patient, and the quality of life is improved tremendously. There are other treatments also which have been tried, like stem cells and all, but these have all been proved to be a dismal failure. Thalamotomy, pallidotomy were older surgeries and it involved destruction of parts of the brain, like the thalamus and the pallidum and all that. But now they are not being done because these are not reversible and causes side effects, and the effects may not be that long-lived. The advantage of brain stimulation is that the effects are modifiable, reversible, and not permanent. What are the indications? One is advanced Parkinson's disease with disabling motor fluctuations and dyskinesias, especially drug-induced dyskinesias. Medication refractory symptoms with significant disability. No significant cognitive impairment or psychological problems. 10 years after diagnosis, and most important is patient understand and accept the therapy. That is, they have to understand that this is not a cure for the disease. This is only improving the quality of life, and what all problems in the disease can be improved, they have to understand very clearly. From a surgical point of view, Parkinson's disease can be divided into 3 stages. One is stage 1, which is early Parkinson's disease, which can be managed with medical management. 20% of the patients who, especially those with severe tremors, they need surgery, but most of them can be managed with medical management. Stage 2 is when the medical treatment starts losing its efficacy or side effects start appearing. Surgery is definitely indicated at this stage, and this stage occurs usually 5 or more years after the disease. Besides dyskinesias, motor fluctuations, other indications include pain and hallucinations. Surgery usually resolves most of the symptoms. The third stage is a disease when the patient is virtually bedbound and barely responds to medical treatment and has significant side effects. Surgery may or may not be possible in these cases. Generally, I avoid doing surgeries for this patient because long-term results are very poor. This is a section of the brain that we call it the coronal section. This is, of course, the hairline. And, we actually, as I said earlier, we put electrodes into the brain, and this is the subthalamic nucleus, as you can see. And this is a substantia nigra where dopamine is produced. So our electrodes come like this and go into the subthalamic nucleus. In some patients, there's another area of the brain called the globus pallidus interna, which is here. This also is used as a target for stimulation in Parkinson's disease. This is quite, the decision is based on various situations, which I will come to later. This is the electrode, which has got 4 contact points. And this is a battery which is usually kept in the lower portion of the chest, upper portion of the chest below the clavicle. So how do you achieve, as you saw, the subthalamic nucleus is such a small structure. And how do you achieve the correct target placement? For that, we use what is called stereotactic frames. These are 2 pictures. There's a standard stereotactic frames, which I have shown here. One is called the CRW frame, the one on the left. And the second one is called the Lexel frame. These are the 2 frames which are used internationally all over the world for surgery for Parkinson's disease. And the accuracy for these frames is around 0.1 millimeters. So they are very accurate. So you can see this is a surgical photograph where we have fixed, I use the CRW frame. We have fixed the frame, and we also use what is called a micro drive. The advantage of this is this can push the electrode at 0.1 millimeter at a time. So you can push it slowly, 0.1 millimeter, you can push it. And this is the other end of the micro drive where you have got 5 channels. Usually we put 5 channels which goes into the brain. And this is important because, once you put 5 channels, it is easy for us to get a 3D view of the subthalamic nucleus. Surgery is done under local anesthesia, and patient is fully conscious during the surgery. But the biggest problem is substantial. This STN, the subthalamic nucleus, is not very well seen in the scan, in the MRIs and all that. So how do you find out whether you are in the correct direction, correct plane, and correct target? So what we do is we do micro electrode recordings initially. So we go from, see, we are coming from here, we come here. This is a thalamus and this is a subthalamic nucleus. So when we come down like this, slowly, we get the different various patterns, recording patterns we get. This is in the thalamus, we get this. Once we reach the subthalamic nucleus, we get this pattern. And once we cross the subthalamic nucleus, as I showed earlier, there's a substantia nigra. You get this pattern. So we know that we have crossed the subthalamic nucleus and entered the substantia nigra. So this is how it looks like during surgery. If I told you 5 channels, all the 5 channels are recording, and all of them are inside the subthalamic nucleus. But here the red and the green are, red, green, and white are very much inside the nucleus. So then once we have, we know which are the best places where we can stimulate, we do what we call stimulation studies. We take out the recording electrodes and put stimulating electrodes and stimulate from outside. So this table helps me to understand whether I am in the correct position. So if the electrode is too medial, then I get the patient will complain of diplopia or deviation of the eyes. If I'm too anterior, the patient will develop muscle contractions. If I'm too superior, if I'm too inferior, the patient will have echinacea. His movements will start, he will become uncomfortable. So like that, by trial and error, we find out which is the best position for the electrode. Symptoms which are improved, tremor, most of the times tremor improves by 100%. Most of the symptoms improve 80 to 100%. Independence and quality of life are substantially improved, and the usual complications are less than 1%. It includes hemorrhage, infection, and mechanical causes. This is a post-operative X-ray of the patient. You can see this through small holes. This is the electrode is put in. This is a connecting wires to the battery in the chest, and this is how it looks like during surgery. This is a post-operative MRI. You can see the electrodes in the subthalamic nucleus. I would also like to show a very short video of a surgery for Parkinson's disease. Of course, the surgeries are quite long and takes a long time. But here, we have edited to very short duration so that it's easy for people to understand. What you will see is the initial patient presenting with severe tremor, especially of the left side. He has got tremor both sides, but left side is more, and also his walking is quite difficult. Please see. So you can see the tremor of the hands and the legs. Now the hands are having so much tremor, and the legs also will have a lot of tremor. It is because because of the tremor he cannot walk properly. He has to hold on to somebody and to see the leg. So he's having so much tremor. And then he will start walking now. Once he starts walking, you can also see a process called freezing. That is, when he goes in front of a door, he automatically stops. See, this is freezing. So for moments, sometimes he freezes for over 15 minutes and all. He's like a statue. He gets stuck there, and somebody has to come and practically push him across. This is another common problem with the Parkinson called freezing. Freezing is a very big problem for some patients. People won't believe that. You can just see, just watch. He will stop for a minute. See, he is frozen. Then that brother, he actually pulled him. Then only he could walk in. Okay, see that now I am showing the operative surgery videos. As I showed you, we do a lot of recording from the brain. And this recording, you can see the initial recordings from the brain. This is a micro drive, and this is the recordings which is going on. And you can see the recordings from the brain. Okay, the stereotactic frame, you can see the micro drive, you can see. And we'll start the recording. We already started the recording. We are going down, and we will be reaching the subthalamic nucleus very soon. Yeah, this is the pattern of the subthalamic nucleus. As I showed earlier in the picture, you can see the subthalamic nucleus pattern. Only one contact point has reached, only one electrode is reached. The rest of them is not reached yet. Slowly they will reach. But we will decide which is the best one, as I said earlier, by our stimulation studies also. Now I want you to see the stimulation study. See, actually he's having tremor. And once I asked my colleague to put off the battery, the tremor stops immediately. So kindly watch carefully. And then when we put off the current again, the tremor will restart. Please watch carefully. Now the battery is off. On. See, you can see. The moment it is on, the tremor stops automatically. And I was telling you, the patient is fully conscious during the surgery. Please watch. He will do whatever we say. He will move his hands, say his name and all that during surgery, and his hands also become very soft and supple. And there's no tremor, nothing. And see, he is doing. See, he is fully conscious. He is doing himself. So this is one surgery which is done during. There's assessment during surgery. The patient is fully conscious during the surgery. So slowly, by trial and error, we find the correct place for the electrode, and then, based on the thing, we do the stimulation also. So when what I'm saying is, when we stop the current, his tremor and disappeared. When we started the current, his tremor disappeared, and his hands become very soft, and his legs also become very soft. See, he can do all movements. Thank you very much.
It was an absolute pleasure listening to you. Very well presented session. This brings us to the end of this session. Thank you so much, Dr. Ramnarayan, for your time and effort in putting together this interesting session. To our dear viewers, thank you so much for attending this session. Do share any more questions if you have. Until we see you again, take care and happy docplexing. Thank you.